My name's Laura Burke. I'm an assistant professor of emergency medicine and a health services researcher. And in this talk, we want to talk about the benefits and limitations of using Medicare data, how to use it if you choose to do so, and how you can use other data sets in your research. So presumably, you are a health services researcher or interested in health services research. And I'm a health services research enthusiast. It is so important for us to engage in this work because everybody has opinions about emergency medicine, about the role we play in healthcare delivery, whether or not there are too many ED visits or they cost too much. And unfortunately, there's often not a lot of evidence to support the debate that's going on, or a lot of the time these opinions are flat out contradicted by evidence. And we need to inform this debate, but with high quality empirical evidence. And health services research is a great way to do so. And these are a few examples of ED health services research studies that have made the headlines using these data sets. So it's really important that we engage in this work to make sure that our specialty is represented and that our patients have an optimal healthcare delivery system. So what types of data sets are available to do this type of work? Well, there's a couple of broad categories. There's claims data, so obviously Medicare falls into this. There are several other types of claims data sets, so several of the commercial insurers have large national claims data. Again, it's limited to the commercially insured, but if you partner with those folks, you can get access to this data. There's Medicaid data, there's state all-payer claims databases, and these all share a common set of benefits and limitations that I'll discuss. Survey data, so things like NHAMCs, NEDS, NEDS is more in the claim side, but the medical expenditure panel survey, these all have additional levels of detail that aren't available in claims alone and have been used in ED research. Registry data, again, if you really need clinical data, registry data tends to supplement claims data with other collected clinical data that is important for certain diseases. And then finally, there are other types of data sets, state administrative data sets that a number of folks have used to do high-quality health services research. So how do you choose? And that really depends on the point of your study, what you're trying to look at, and an understanding of the benefits and limitations of each of these types of data sets. So for Medicare, Medicare has a lot of advantages. So it's a national data set with over 55 million Medicare beneficiaries. Now, it's a population of interest. It's only a single payer, but there are a large proportion of inpatient hospital stays and about a quarter of all ED visits. So again, it's really helpful to use this data set, and a lot of it's generalizable to other populations. But I think one of the most important aspects of Medicare data is that it has data on outcomes just beyond the ED visit and the hospital stay, which I'll get into. Also, unlike some of the other survey data sets used in emergency medicine, you can identify individual hospitals based on their provider number, and you can link to other data sets because of that. You'll have patient-level zip code, hospital-level zip code, and you can identify the actual hospital and link to a number of rich supporting files. There's a good community of researchers using this data set to rely on and get additional information. And ResDAC, which is the CMS basically support center for Medicare data, is really responsive and available to answer your questions. So to talk about some of these advantages, so being able to see what happens outside of the hospital encounter. So a lot of like NEDS and HCUP, you can mostly only see what happens in the ED or in the hospital. But for Medicare, you have their death date, regardless of whether or not that death occurs in or out of a hospital setting. So you know if the beneficiary died, no matter what. And you also have their other claims if you get those files, so outpatient files, physician claims, home health, durable medical equipment, so you can really get a full picture of what's going on with the patient. So an example of this, Ziad Obermeyer, actually, at the Brigham, who worked with some other health economists, looked at percentage of patients who had a death within 7 days of ED discharge. This wouldn't be possible using a claims data set that doesn't have data beyond the hospital stay. This looked at all deaths following an ED visit using Medicare data. Work that I've been fortunate to work on with the Medicare Payment Advisory Commission is looking at a quality measure called Healthy Days at Home. And there we were able to look at percentage of time Medicare beneficiaries were alive, but also out of facility-based healthcare settings because we had all those different types of claims in detail. Costs. So everybody talks about ED costs, which is important. It's important that we're good stewards of healthcare resources. But a lot of the narrative fails to put our costs into greater perspective. So using Medicare data, you have all the claims for a Medicare beneficiary, and so you can calculate their standardized costs. And if you look here, here's some work that we've done and we've presented at SAEM. ED visits are a small proportion of total healthcare costs for Medicare beneficiaries. That's true for high-cost patients, that's true for non-high-cost patients and beneficiaries overall. And because you can look at all of their healthcare utilization, you can put ED spending in perspective. So what are some downsides to using Medicare? Of course, it's only one payer. So if you want to study the uninsured, this is not the data set. I will say we have duals in Medicare data, so really it's just Medicare dual eligibles. One limitation has been the growing percentage of beneficiaries using Medicare Advantage, and they have traditionally not been in most Medicare data sets. But starting in 2015, Medicare Advantage encounter data is becoming available to researchers, and it's now available for researchers who order it. So that is one limitation that's starting to be overcome. It's expensive. So Peter's going to talk a bit about this. There are a couple ways to access this data. I've been fortunate to partner with a senior health services researcher with a lab that's built up years of Medicare data with grants over the years, and that's how a lot of people do it, is they basically collaborate with someone who's already using it, get expertise, and eventually you get your own grants to pay for the data. But as Peter will go into, there are other ways to access this data without actually physically ordering the data and keeping it on your own server. There's a learning curve to using it. I think it's similar to other claims data sets. It has greater detail, but it does take a significant investment in understanding what's in the files, the different claim, line level, and how you clean it and use it. But once you do, it's really a powerful data set to use for this research. And then some other really important limitations are shared by most claims data sets like NEDS or all-payer claims databases, is there's limited clinical data. It wasn't designed to measure clinical outcomes per se, it was designed for billing. And so while it can be used for health services research, understanding that limitation is important, and it is a critical flaw that prohibits some types of studies. And for all claims data, if the ED patient is admitted, a lot of the data isn't captured. So for outpatient claims, you have a greater amount of detail on work that's performed in the ED. But because payment for ED facility claims doesn't occur if they're admitted, it's part of the hospital claim, there's less available to see what happened in the ED. So some examples of these strengths and limitations. So if you really need all payers of the uninsured, terrific recent study in JAMA Internal Medicine by Arjun Venkatesh at Yale showed that patients who were uninsured or had Medicaid were more likely to be discharged rather than admitted for conditions like asthma, and they were more likely to be transferred when there really shouldn't occur for clinical reasons. So this is an important health services research study that wouldn't be possible with Medicare because you really needed other payers to evaluate this. So NEDS was the database they used in that study. Adam Singer and Jesse Pines looked at the percentage of ED visits among the uninsured using NHAMCs. Again, this is a survey data set that has all payers that can address this type of question. Rene Shah is an obviously superstar health services researcher that has used the California data set, among others, to just really give a detailed picture of healthcare disparities and adverse health outcomes associated with ambulance diversion, and again is another example of a data set that can answer these questions. So what if you really need clinical detail? A lot of these will not have it. So that's where registry data can come into play. So stroke is an example of a disease where the CMS risk adjustment model has really been shown to not be ideal because you need NIH stroke scale, and claims data sets don't have that. So Corey Zackerson at MGH used the Get With The Guidelines registry linked to claims data. AHA has some registry data that's actually you can apply and they'll do the analytics for you. I have a colleague that did that. So registry data is a great option for people who really need additional clinical detail for select diseases. And then chief complaint. None of the claims data sets have chief complaints. And obviously for emergency medicine, that can be a big limitation. Patients don't show up with diagnoses. claims data have diagnoses, but not chief complaint. And this is one of my favorite studies of all time. But in NHAMSES, the study by Maria Raven that showed that these retrospective denial of payment for ED visits based on the diagnosis really isn't based in empirical evidence, that it just doesn't correlate well with the chief complaints. And the same chief complaints for non-emergency diagnoses are also the chief complaints for serious ones that need emergency medical attention. But if you need chief complaint, NHAMSES is really the data set to use. This was presented yesterday. This is really elegant. It was an abstract that was presented yesterday. If you need vital signs, most of these data sets won't have it, but NHAMSES does. And so depending on what you need to know what's available. And these are some examples of ones where Medicare data will not work. That being said, I have really enjoyed working with Medicare data. There are lots of researchers that use it to do high-impact, peer-reviewed research. You just have to weigh the risks and benefits for your individual study. And so with that, I'll pass it on to Peter. Thank you.
So you might then ask, what the heck would that do in a slightly humorous take on how to start? Well, I think it's actually pretty simple extrapolation, in that really the decision to be a researcher using Medicare claims is kind of like running a startup in some ways. There are huge barriers of entry to the economic marketplace of being a researcher using Medicare claims. So you have to understand those, and hopefully we can give you some tips for what you can do to kind of circumvent some of those entry barriers and allow you guys to be a successful startup. I think I would kind of put it into 3 categories. So that would be cost, computer processing power, and expertise. So let's go for those 3 in order. So cost, first of all. What is the cost of accessing Medicare claims? So there's 2 ways that I'm going to talk about that you can access the data. And maybe I'll just even bring it up at the moment, which is you can, as Laura mentioned, you can purchase the data files and have them on your own servers. Or you can purchase what we call a seat through the VRDC, which is a virtual center through Medicare, where you can actually access it through their portal, essentially. And they'll give you the data sets once you sort of purchase a seat. But even with purchasing a seat, which is about $40,000 a year per seat, and then it can raise to upwards of $60,000 or $70,000 a year to actually purchase the data files that you actually need. So that in and of itself is a major hurdle for researchers that are just starting this process on their own. And I'll talk in a little bit about why you don't even need to do it on your own then. So second is computer processing power, and that's not a huge hurdle, but it is a hurdle. You actually need computers that can do significant complex modeling on millions of visits a year. And not even just the computer processing, but the time it takes. In the study that I'm going to show you in a little bit that we're doing, the computer analyst has the models running for 12 to 24 hours at a time. That is major lifting. And so you just have to have the bandwidth and the support and infrastructure to be able to do that. And the third I mentioned is expertise. I don't do this analysis. Laura does some of it and is better at it than I am. I have recognized my limitations as a researcher, but also know that we have analysts who have extreme expertise in the use of both claims data and Medicare claims data. So you have to be able to partner with analysts who are either familiar with Medicare claims or familiar with really using claims data and have sort of at their elbow mentorship in doing so. So the way that most people, at least at the start, end up sort of circumventing a lot of this and getting past some of those barriers of entry is to find a mentor or find a team of people that are already doing the research. At many of your institutions, there are folks that have already have the Medicare claims data and have networks or have analysts that are doing the research. So at my own institution, we're fortunate to have, amongst other things, so Laura works a lot with Harvard School of Public Health. I work with a mentor at the Department of Healthcare Policy at Harvard, and they have a research infrastructure already. So I teamed up with my mentor, who already had access to the Medicare claims, the analysts, and put in a grant under them.
So that's how you can start to use this data without having to expend $40,000, $60,000, $80,000, find your own analyst. But for those of you maybe who are leaders within your departments, you can do this. You just have to set aside some money, both for the computers, or sorry, for the databases, and to make sure you have an analyst. And work with other departments and share those resources, because I think that's the only way that you can get this off the ground. As I mentioned, there are just two simple ways that you can access the data. We're doing both of these through our work and finding that it can be supposedly more efficient and timely to access the data through the VRDC. There is still a little bit of a lag in Medicare claims. So right now the data is available through 2017 and it updates on an annual basis. I'm going to briefly give you an overview to the claims files. I'm not going to go into too much depth on this because it can be head-spinning, but I found this to be almost the most complicated topic, was even just to understand what files there are and what they do. So I think there's 4 basic ones that emergency care researchers are going to need to use. The first being the beneficiary summary file, which, as the name implies, talks about the Medicare beneficiaries. So their demographic data, whether they're alive or deceased, their reason for Medicare entitlement, and so on. There are some supplementary files also that are attached to the beneficiary summary file. Mainly the one of interest for me is called the Chronic Conditions Warehouse, which is for when you need to have measures of comorbidity. It gives you a count of 27 coexisting conditions and the year at which the patient developed that condition. So you can use that to create your own measures of comorbidity. So the carrier file is not one that you will always need to use. The carrier file basically allows you to link to the provider, the emergency care provider of interest. And for some of you who are doing research where you just care about the hospital level or the regional level or whatever, you may not need the carrier file and you can do all of your research with the outpatient or the inpatient file. For our purposes, when I'll show you just an example, we were looking at physician level rates of admission from the ED. So we needed the provider's NPI number. And we can get that from the carrier file. It also includes a marker of what the specialty of the physician is. So we can tell whether they're an emergency physician, internist, family medicine, and so on. Although not as accurate, I think, as the Doximity file, which also allows you to have physician-level characteristics. And then quite simply, the outpatient file includes all patients that were seen and discharged from the ED. Now, of course, you can also do other outpatient utilization data from that. But if you're just interested in identifying ED visits resulting in discharge, you get those all from the outpatient file. And ED visits resulting in admission then all come from the inpatient file. And as Laura mentioned, one of the biggest limitations is that the testing that's done in the ED on admitted patients is pretty much impossible to tease out because of the way the facility claims are processed.
But that's true for almost all claims data.
Yeah. Now, you're totally right. One of the things I was thinking about is for those who are on systems like Epic or Cerner or have access to maybe when they sort of collate that into large-scale data, that's going to be a really powerful tool as well because you'll have probably millions of visits, especially for Epic, and include probably all the levels of data. But I don't have any idea whether that's actually available at this point. All right, so kind of on the home stretch for this. The last piece is what do you need to do, or what does your analyst really need to do when you're working with Medicare claims? The first is going to be identify ED visits. This can be very complicated, and so all I'll say is if you're going to work with Medicare claims, take Arjun Venkatesh's paper that's listed there at the bottom and read it through. He gives a really thorough analysis of some of the types of ways that you can break this down. And we took that and did some other work, and I wrote down here, just so you can even copy it down or take a picture, whatever you want, using the carrier file, these codes that are the E&M codes, plus including critical care and observation and a place of service for the ED. It looks actually quite simple, but it took months to actually figure out that as a reasonable strategy. You can also identify the clinical condition, so you can go to the HRQ website. You can download what's called the clinical classification software that allows you to take all the ICD-9 codes or ICD-10 codes and lump them into clinically meaningful groupings. You can identify, as I mentioned, measures of comorbidity, including the CCW and then the HCC, which is basically a measure using Medicare demographic and diagnostic data that has been predictive of future healthcare spending amongst Medicare beneficiaries. And then you can link to some interesting other resources. So if you need to have hospital characteristics, like rural, urban, whatever, teaching hospitals, you can get it from the AHA survey and link that to the hospital identifier. If you want to have physician characteristics, you can get the Doximity survey, and you can link it to the physician characteristics. And if you want to have geographic variables, you can link to the area resource file for county-level data or to the HRR, hospital referral region data from Dartmouth. Just as a really one example, and obviously I'm most familiar with my own work, and I just want to use this to highlight what you can do and the power of Medicare data. This is basically a physician-level analysis of work that's in progress right now of showing variation in rates of admission from the ED, again, at the level of the physician. So you can see on the left panel the distribution of variation across physicians. So there's substantial variation in rates of admission. But then when we add a fixed effect for region, which is the middle panel, you see actually things don't change that much. So this is kind of interesting and maybe counterintuitive that geography doesn't matter that much. And then we add a fixed effect for hospital, and you can see the shrinkage so that we see that actually much of the variation at the physician level is dominated by influence at the hospital, which I thought was really an interesting finding. I'm not here necessarily to go over all the findings of this, but just to show you that this was a study using about 6 million ED visits, 45,000 emergency physicians, and 5,000 EDs. So there is great power in using Medicare data. So finally, obviously I don't recommend that you steal our work or anybody else's work, as Steve Jobs and before him Pablo Picasso would have said. But there is no reason for you all to have to recreate the wheel. Ask us. Ask people who have used Medicare data. There are enough researchers and health services research at this point who have used this and know what to do that we're always more than happy to share what we've done and the methods to get there. So thank you very much. We appreciate your time and happy to answer any questions.